Afternoon. First and foremost, I think it's nice to see such good representation from EasyJet here today at a healthcare conference. I'll try and be as brief as possible, knowing that we're a bit behind and I think everyone's probably edging towards lunch. A little bit about me before, and this isn't a CV, I promise, I'm not looking for a job. I've been in the healthcare industry and the procurement industry for over 20 years. With both private and public experience. I've done a lot of work around implementation of ERP systems across Europe, so understanding catalogue management, understanding change management is key. Where I stand at the moment within Northampton is head of procurement, driving a programme supporting the enablement. I'm part of the Midlands Customer Board, looking at collaboration across the whole of the East Midlands, and I'm part or linked in with Steve Graham's team looking at data as part of that task force. Northampton is a typical mid-sized hospital. We've got the same problems as probably most NHS trusts within the country. We're struggling with finances. We had a deficit in 14-15. We're projecting another deficit in 15-16. We, although are improving our A&E times, as with most organisations, we're failing on the 4-hour. Pretty typical. I think last month we hit something like 93 years against the 95%. What's slightly different maybe is that the organisation more recently is moving to be a clinically led organisation. Our chief exec is an ex-clinician consultant, and now we're moving more and more towards that type of organisation. We've submitted our business case to the TDA, and that TDA business case is suggesting that we will be running close to a 21 million deficit for 15-16. That, for me, means that from a revenue point of view, we can't exceed that. There'll be significant penalties on the trust if we do. So there's a cap to what we can do, and that's what we're projecting for the coming financial year. We've done a number of things around inventory management business case, around GS1. We also actively benchmark. We use a benchmarking tool that looks at a number of trusts. I think it's about 70 trusts now nationally that we benchmark our procurement data against, so we start to compare prices. And as an indication of that alone, we've saved over 50,000 in benchmarking in the last 3 months alone. So that's something we are actively doing. And more recently, I think we're one of the few, maybe even the first trust to submit a GS1 board-approved plan to Owen, which I think went in towards the end of May. Why are we doing this? Not because we're being told to do it through the e-enablement strategy. I think we're doing it for a number of reasons. Patient safety is critical. As it says at the very top there, I don't actually believe any other programme has the potential to improve every part of what we do within the organisation. And I think going through this journey of GS1, that sort of highlighted it to me as to how many touch points within an NHS trust this type of programme will impact. From Northampton's point of view, we were lucky that the board took some educating, but the board fully acknowledged the benefits of GS1. They recognised the need to have or the benefits, sorry, to have the right product at the right time, at the right price. Critical. They recognised, and I think there was a colleague from the MHRA mentioned around the PIP implant issue, and also metal on metal from Northampton. Metal on metal, the recall of that did cause issue. This sort of programme would enable us to very quickly and easily identify patients who have had an implant that has been recalled at a later date. Very, very difficult, manual, laborious process at the moment. Also from service line reporting, we recognise that the missing link at the moment, we can look at theatre utilisation, etc. What we're not linking is the product to the patient. That's, for us, again, quite a critical factor. GS1 will help support that. So where do we start? We started some years ago. It mentioned there 2012. We had an audit report that came back showing that if we looked at areas or hospitals of similar size to us within the locale, our inventory stock holding was increasing quite significantly in comparison to other trusts. So that audit report highlighted the need to invest in some sort of inventory system. In December, we started a program to look at, so December 13, to look at inventory. I pushed this through as a transformation project. It took some negotiation through the Director of Finance, etc. Nonetheless, we eventually got to a point that they agreed to fund and support a business case, the writing of a business case for an inventory management solution. We had some external support. We wrote that business case very late in 2014 and submitted it to board early 15, and we got approval on that. What we then started to look at is the business case for GS1, supporting again the enablement. I'll be honest, we are quite keen to become one of those demonstrator sites if we can. Therefore, we recognise the need to get the GS1 approved plan to the DH by the end of June. Now, our board meets on a monthly basis. That meant getting something to board by the end of May. It was a tight agenda. We managed it. We got it through. So our board-approved plan has gone through. It's gone through to Owen. And one thing I have to recognise is that as a trust, we had some very, very good engagement from the chief exec all the way through. Department heads, everyone that we approached was open and willing to get involved and engaged in this programme. We also, as it said at the bottom, registered with GS1. So taking Rachel's point, we've got a GLN. We know what that is. We're not quite sure what to do with it yet. That's part of obviously the journey moving forward. How we engaged. Now, I'm not suggesting that we all go out there and start engaging or trying to betroth ourselves to the chief exec or any of the exec team. But it was interesting. I looked at Wikipedia, and that's what came up as a definition for engagement. But there's some interesting words that come out of that. For me, it's around the promise. There's a commitment to this project. So if you're going to engage, we need those individuals engaged to promise that they will be involved. We accept that the period of time of an engagement can be quite lengthy. And there has to be a commitment to be involved. We also suggest at the very end, from an intended point of view, we need the board or those involved to support whatever the solution is. So if you're getting a board-approved plan to support GS1, they have to follow through with that. Who we engaged, I've alluded to the fact that we had very, very good support. We had excellent support from the exec team, although it was interesting when we first, I think I nominated a GS1 lead from an exec board, was nominated by the chief exec. I think his first words were, what is GS1? What is this barcoding thing? So we've had to do a lot of education around what GS1 is. Nonetheless, we got good support. We got very good support from the heads of department. We've listed there only a few, ICT, pharmacy, medical, it goes on and on and on. That's when you start to get into this program, you do realise the touch points within the organisation. What I will say though, although it's not, and I don't perceive it as a procurement project, it was interesting that with this, it was procurement that led it. That's one of the challenges moving forward as to where does this sit as a project within an organisation. I think certainly procurement have a huge input into it, as do IT. But it needs to be really supported by the exec, and it needs to have exec support and an exec lead. Without that, you're not necessarily going to get your voice heard within the exec team. As I said, we were lucky. We got very, very good engagement across the board, and interesting enough, even from clinicians, we're getting approached by clinicians who are understanding the benefits of GS1 and traceability of not just implantables, but also medical equipment, which is a huge issue. Some of the barriers, as I mentioned earlier, our nominated GS1 lead, and to be fair, the board didn't understand what GS1 was. That took some educating, that took some time to explain to them what it was, but more importantly, what the benefits were. We've also got some other major IT projects underway within the organisation, which have almost depleted our IT capital budget. Things like, it mentions their Vital Pack, the ability for clinicians to be holding handheld devices that allows them to see all the demographics and all the clinical information on the patients that they deal with without actually being in front of the patient. It's taken a huge amount of money and effort. We're also moving forward with the replacement of our PAS system. That's gone to TDA for approval. Again, that's a significant expense to the trust, therefore very little money available to do anything of this type with, both from GS1 or even an inventory perspective. Change management, I don't think, has been fully acknowledged by the organisation. Working within the private sector, I implemented JD Edwards, which then became PeopleSoft across Europe. Even within the UK, change management was a significant issue and something that took an awful lot of time and resource to overcome. You're asking the people to actually change their practice and the way they work. As a suffering trust, financially, again, cost is a huge issue. We haven't got the revenue budget to do this. At the moment, we haven't got the capital budget to do this, saying that, although, if we don't become a demonstrator site, we've already put plans in place to go to the TDA. We've put plans and a business case to them to say, look, we want to invest in inventory management. We're the GS1 backbone as one of the enablers, and we need money to do that. So at the moment, we're looking hopeful from a TDA perspective that helps support us, but that can only be from a capital point of view. From a revenue, we're still struggling. Resource, again, is another issue. As I mentioned, this program at the moment has really been driven by procurement. It needs more than just procurement. It needs a dedicated project manager to support and move forward. It will take a huge amount of my time, as well as my day job. And that's something that the trust and all organisations need to recognise, both, I think, private or public. So, what was the result? From our point of view, we had the exec team fully engaged with both the philosophy of GS1 and of inventory management, which is the other main thing that we're looking at. And they approved the plan. And when I was presenting to the board, without exception, everyone acknowledged the benefits this could bring, and everyone, without exception, approved the plan before it went to the DH. We've also got moved forward a board-approved plan for inventory management, so that's going to happen regardless of whether we get external funding or not. It's just the scope of what we do may be limited. We have got a GS1 program team essentially established. We just need to look at who's going to project manage that at a head level. And we've already published our plan and we've shared it with our colleagues across the whole of the NHS. But I must say that, as it mentioned, red at the bottom, it is only a plan. Each one of the individual cases, be it inventory management, be it medical records, are all going to require their own mini business cases in isolation. So we just asked the board to approve a plan rather than approve individual projects. What next for us? We are working with IT to look at other technologies. RFID is a key element for us. It's quite a shocking statistic up there when you look that out of our 7,000 assets, 14% are missing at any one time. That's with pumps going into community, departments hoarding. There's a huge amount of lost opportunity sitting there and potentially patient safety issues. We need to look at the EU legislation. At the moment, it's only a recommendation, but as a recommendation, we know what's coming around the corner is going to be the ability to link any implantable or medical device to an electronic patient record. At the moment, we all know from a prosthesis point of view, there's the paper medical record, and they're taking the sticker from the prosthesis and putting that against the medical record. Although it's only a recommendation, we know legislation's around the corner. We're going to have to do something sooner or later. Mentioned we're already exploring other funding models through the TDA, and at the moment they're being heard positively. And from my point of view, we now need to look at how we drive the whole thing forward. That is me. I thought, not quite 15 minutes, but it's time for lunch. Thank you.